Quality care is no longer just good medicine. It's also good economics. The No Pain Act is breaking cost barriers. Before the No Pain Act, hospitals and ASCs absorbed the full cost of Exparel because it was bundled into Medicare's outpatient payment. This created a financial penalty for choosing non-opioid pain management, despite clear benefits in reducing opioids and improving recovery. The No Pain Act, passed as part of the Consolidated Appropriations Act of 2023, commissioned CMS to reimburse for qualifying non-opioid drugs and devices used in ASC or HOP settings for 3 years. Qualifying drugs must be indicated for post-surgical analgesia with demonstrated efficacy in reducing opioids in managing post-surgical pain. Starting January 1st, 2025, the No Pain Act mandates a payment of the average selling price plus 6% reimbursement for those qualifying non-opioid therapies like Exparel in both ASC and HOPD settings. It dramatically lowers the net cost of non-opioid therapies, and it removes barriers so hospitals and physicians can choose evidence-based, opioid-sparing options without financial loss. By stabilizing the economics around non-opioid care, the Act helps facilities maintain quality, reduce opioid exposure, and support better patient experience measures like HCAHPS. In short, a former financial penalty has become an incentive for opioid stewardship and patient-centered pain management. Before the No Pain Act, the economics of outpatient surgery made it difficult for facilities to use Exparel. For laparoscopic inguinal hernia repair, surgeons receive roughly $626 from Medicare and about $650 from commercial payers. Facility payments are modest as well, about $1,621 in the ASC and $3,296 in an HOPD. And that amount must cover all staff, supplies, and medications. With Exparel priced at around $400 per vial, the drug alone consumed a large share of the total facility payment. For physician-owned ASCs, this frequently meant reduced or negative margins. Beginning in 2025, the cost structure for Exparel changes significantly. A 266 milligram vial averages $380 to $400, and Medicare will now reimburse that amount plus 6%, paid separately from the procedure itself. This removes the need for facilities to carry the drug cost inside the global payment. Commercial insurance coverage still varies by contract, generally ranging from $400 to more than $600 per vial. This updated payment model finally makes the use of long-acting local anesthetics financially practical, allowing facilities, including the physician-owned ASC, to offer opioid-sparing pain control without weakening their margins. To receive full payment for Exparel, precise documentation is essential for the initial order through final billing. In both the ASCs and HOPDs, Exparel must be billed under J0666, the Medicare J-code that enables separate payment. The surgeon's order should clearly identify Exparel for use in a regional block that supports opioid-sparing post-operative care. The anesthesia team should document that Exparel was administered as part of a long-acting regional technique. In the operative note, you should include Exparel 133 milligrams or 266 milligrams was administered as part of a long-acting nerve block for specialized regional anesthesia to relieve pain from an approved surgical procedure. This ties the clinical indication directly to the reimbursement rules and helps prevent denials. Coders should use the updated 2025 CPT codes for the specific block performed and list the dose in milligrams, not milliliters, since reimbursement is based off of drug strength. Following these steps ensures accurate claims, supports compliance, and captures the full value of Exparel in postoperative pain management. The No Pain Act does more than cover the cost of long-acting regional anesthesia. It supports the quality metrics that drive Medicare's value-based purchasing program. Now, value-based purchasing places 2% of a hospital's Medicare payment at risk, adjusting reimbursement based on overall quality performance. A hospital's outcome is determined by its total performance score, which can result in either a penalty or a bonus. Because value-based purchasing is budget neutral, dollars withheld from low-performing hospitals fund bonuses for high performers. The score is based off of 4 domains. First, clinical outcomes, which is 55%. Regional anesthesia and opioid-sparing strategies reduce complications, readmissions, and recovery delays, all of which strengthen outcome scores. Number 2, patient safety, which is 15% of the total performance score. Lower opioid exposure decreases risks such as respiratory depression, delirium, and post-operative falls, improving safety metrics. HCAHPS, or patient experience, is 25% of the total performance score. Long-lasting regional analgesia improves comfort and participation in recovery, supporting higher patient-reported experience scores. Efficiency and cost reduction is 5% of the total performance score. Fewer opioid-related complications and shorter recoveries reduce episode costs, improving efficiency metrics. In effect, the No Pain Act supports both financial stability and quality advancement by enabling hospitals to deliver safer, opioid-sparing care that moves them towards stronger value-based purchasing performance. So let's look at the average estimated cost of a total knee arthroplasty in the United States, which is roughly $27,500 per case. Now, this number represents a blended national estimate across outpatient and inpatient settings. It's important to remember that this is only an average. Actual costs vary based on factors like geographic region, surgical complexity, implant selection, and differences in post-acute care. So this figure provides a general benchmark, not a precise prediction for any specific hospital or patient. We can see how value-based purchasing directly influences hospital revenue. In the Medicare value-based purchasing program, 2% of hospital reimbursement is placed at risk each year. Depending on the hospital's total performance score, that money can be lost, or it can turn up into a bonus of up to 5% for top performers. If a hospital system brings in about $50 million annually from Medicare total knee arthroplasty cases, a poor quality performance results in about $1 million loss, or roughly $550 per case. On the other hand, top-tier performance can generate $2.5 million bonus, averaging about $1,300 per case. Hospitals that focus on opioid stewardship, enhanced recovery pathways, and patient satisfaction, which are the very goals of the No Pain Act, are rewarded with higher reimbursement. In short, quality care is no longer just good medicine. It's also good economics. I'm Dr. Reed Nelson. Thank you for listening.